Good morning, everybody. So welcome to the teaching session of Department of Urology, Sawai Singh Medical College, Jaipur. Today we will have a presentation on urethral injury, lower urinary tract injuries, and this will be presented by our resident, Dr. Sudeep, and will be moderated by our faculty, Dr. Ajayraj Singh Hada. And today we are fortunate to have two experts with us. One probably will soon join, Dr. Pankaj Joshi from Pune, and Dr. Sanjay Kulkarni might also join. So welcome all of you. And I would now request Dr. Ajay to kindly request Dr. Sudeep to begin his presentation. So, okay, Sudeep, you can start your presentation.
Good morning, all of you. Today's topic of seminar is management of lower urinary tract injury to be presented by Dr. Sudeep Singh. Now I request Dr. Sudeep Singh, please proceed. Sudeep?
Yes, sir.
Good morning, everyone, respected sir, respected faculty, and my dear friends. Today, I am going to present a seminar on the management of urinary tract injuries.
Today I am going to present a seminar on the management of urinary tract injuries. Screen share, sir.
Yes, Zoom. Screen is being shared, sir, from my side.
Screen share.
Recording in progress.
Go ahead.
Good morning, everyone. Today, I am going to present a seminar on the management of lower urinary tract injuries. So coming to the introduction, the lower urinary tract includes the bladder and the urethra. And the most common etiological factors, it includes the vascular injury and the iatrogenic injuries. The urinary bladder injuries. So it is broadly divided into extraperitoneal injury, which accounts for more than 80% of the injuries, and intraperitoneal injuries, which account for 20% of the injuries. The most common associated injury is the pelvic fracture, which is associated with more than 83 to 95% of the bladder injuries. And one half of all the bladder injuries are iatrogenic. And they are most commonly because of the obstetric and gynecological complications during surgery. Laceration is the most common mechanism of intraoperative injury. And some endoscopic injuries like transurethral section of bladder tumor are also associated with the bladder injury.
The screen is not coming. Just go back. Just try to.
स्क्रीन ऑन दे कोई वीडियो बंद कर
इसी को बंद करवा
थंबनेल है ना वीडियो थंबनेल हां बिल्कुल
Some technical issue. We will just start soon. So in the meantime, Mr. Nimesh has. Is it okay? Are you getting the first screen?
No, sir. Screen not visible.
Okay. We will just see what is the problem.
In the meantime, Nimesh.
Yes, sir.
What is the problem?
Dr. Sudeep, kindly unshare your screen. Then Again, share your screen.
Stop share करके नीचे करके वीडियोस बंद कर दो नेटवर्क इशू की वजह से लास्ट टाइम बंद हो गया स्टॉप वीडियो स्टॉप शेयर ये वाला करने नहीं ठीक है आया क्या
Make it full screen.
फुल स्क्रीन मैं फिर दोबारा अपनी स्क्रीन राइट शेयर ऑन करें और हमारा सारा बंद करके बाद स्टॉप शेयर करके शेयर करना वीडियो बंद कर लो वीडियो बंद सारी सिर्फ स्क्रीन शेयर करो वीडियो बंद अच्छा सर मैं समझ गया कैसे करना है मैं करता हूँ सर आप अंडरस्टूड ये वाली शेयर करना आ रहा है जैसा आ रहा है ठीक है go ahead I'm extremely sorry for the technical problem. I'll again start with the bladder injuries. The bladder injuries are divided into extraperitoneal and intraperitoneal injury. The extraperitoneal account for more than 80% of the injuries and the intraperitoneal injury account for 20% of them. Most commonly associated injury is the pelvic fracture. One of all the bladder injuries are iatrogenic. Most commonly are the obstetric and the gynecological complications. Laceration is the most common mechanism of intraperitoneal injury, of intraoperative injury. Some endoscopic procedures like transurethral resection of bladder tumor are also associated with the bladder injury. So this shows the incidence of bladder injury in common pelvic surgeries. We can see that laparoscopic hernia repair has the maximum amount of 1.6%, and in case of laparoscopic total hysterectomy it is 0.75, and vaginal hysterectomy it is less than lap, it is 0.51%. So what are the clinical indicators? The clinical indicators include suprapubic pain or tenderness, free intraperitoneal fluid on the CT. The patient may be unable to void or has a lower urinary output. There may be clots in the urine. The scrotum may be enlarged with ecchymosis. There may be abdominal distension, or the patient may be in ileus. So conscious patients, they present with pronounced non-specific symptoms like suprapubic pain combined with the inability to void. If the blood is noted at the meatus and the catheter does not pass easily, we may go for a single catheter, gentle catheterization attempt. But if it does not pass easily, we can go for an RGU to maybe perform to rule out the urethral injury. But in the clinical setting, this may not be feasible most of the time. So the most reliable indicator is the gross hematuria. In case of intraoperative injury, there may be visible laceration to the bladder, visualization of the Foley's catheter, and there may be extravasation of the fluid into the surgical field. There may be blood in the catheter drainage bag. Whenever the bladder injury is found, it is important to ensure that there is no concomitant injuries to the ureter or the ureteral orifice, which may be checked by just cannulating the ureter. Investigations include the retrograde or stress cystography and a CT cystography. This is nearly 100% accurate for bladder injuries. In the left image, the first image shows a dense flame-shaped collection of contrast material in the pelvis. It is characteristic of an extraperitoneal extravasation. The image on the right, it shows the intraperitoneal extravasation, and it is identified when the contrast outlines the loops of the bowel and the lower portion of the peritoneal cavity. So clamping the urethral catheter in an attempt to allow the antegrade distension of the bladder may be inadequate for diagnosis. So retrograde filling is mandatory. Coming to the grading of the bladder injury, it is the grade 1 is if the injury is just hematoma, intramural hematoma, or there may be a partial thickness laceration. Grade 2 laceration includes extraperitoneal bladder wall laceration, but it is less than 2 centimeters. Grade 3 includes if the extraperitoneal laceration is more than 2 centimeter, or there may be an intraperitoneal breach, which is less than 2 centimeter of the bladder wall laceration. Grade 4 is intraperitoneal bladder wall laceration more than 2 centimeter. And grade 5 is if the trigone may be involved or the bladder neck may be involved. And in case one finds multiple lesions on the bladder, we may advance one grade up to grade 3. So coming to the management of uncomplicated extraperitoneal bladder ruptures. Conservative management is the key with urethral catheter drainage, and cystography is very necessary to verify the complete healing before the catheter removal and after 14 days of injury. So the first image shows a dense frame pattern of the contrast extravasation in the pelvis, secondary to the extraperitoneal bladder rupture. In the same patient, a repeat cystogram was performed after 2 weeks of catheter drainage, which shows a completely healed bladder. So what about the blunt extraperitoneal injury? With the presence of complicating features. Complicating features include if the peritoneal injury is from an external trauma, or there may be a penetrating non-urological injury, or there may be clots in the urine, there may be a bladder neck injury, there may be a rectal or vaginal injury, there may be a open pelvic fracture, or in case a patient needs a pelvic fracture requiring an open reduction and internal fixation. These are all the patients with complicating features. That warrants an immediate open repair to prevent complications like fistula, abscess, and a prolonged leak. And patients undergoing expiratory laparotomy for other injuries or internal fixation for pelvic fracture, it is prudent to perform surgical repair of the extraperitoneal rupture at the same setting. So in case of intraperitoneal injury, it is managed by immediate operative repair. And when explored, the ureteral orifice should always be inspected for clear efflux. We have to ensure the integrity of the ureter. It may be done by administrating an IV dye like indigo carmine, methylene blue, fluorescent green, or most practically a retrograde passage of the ureteric catheter may be done. Although SPCs are routinely advocated, some studies have shown that SPC drainage provides no further extra benefit than urethral catheter drainage alone. Ureteral orifice and the ureters, if they are injured, they warrant primary closure with a stent. Like a DJ stent may be placed over in the ureter, and a perivesical drain is also attached, kept. Intraoperative management in case of iatrogenic injuries. So the lacerations, they need to be repaired in one or more layers using absorbable sutures. The devascularized bladder wall epithelium, it should be debrided, and the closure should be tested by filling the bladder intraoperatively. So the closure, this is very important to check for the closure of the bladder, and we do it by filling the bladder intraoperatively and with saline or a dye, and it serves the purpose of both of allowing additional suture placement if needed, and to reconfirm that no other previously unrecognized injury is missed or not. Then a catheter drainage is draining the bladder is inserted, and intra-abdominal drain should also be left in situ. So most of the series and the meta-analysis show that it is recommended that 7 to 14 days of bladder drainage is needed. And it is very important that whenever an injury is suspected but not visualized, a cystotomy may be performed to facilitate identification of the area of injury. And as said earlier, the ureteral integrity must be established. And especially in case of females, if it involves the anterior vaginal wall, there is a likelihood of post-operative fistula formation. Now coming to the urethral injuries. So urethra is divided into anterior urethra and posterior urethra. The posterior urethra, it is mostly because of the straddle fracture. Straddle fracture is when all the 4 pubic rami are involved, and it results in a vertical and a rotational pelvic instability. And this is associated with the highest risk of urological injury. This image shows the anterior posterior filum of the pubis of a straddle fracture involving all the 4 pubic rami in a patient with posterior urethral disruption, in whom initial perineal posterior urethroplasty failed because there was severe bone distortion. So the bulbo-membranous junction is the most vulnerable to injury during pelvic fracture than the prostatic membranous junction, because the posterior urethra is densely adherent to the pubis via the urogenital diaphragm and the puboprostatic ligaments. And endoscopic and urodynamic evaluation has confirmed that membranous urethral sphincter complex, the sphincter complex, it tends to remain functionally intact even after being avulsed vertically, posteriorly, or laterally from the underlying bulb. The diagnosis, it is made clinically. There is a triad of inability to urinate, there may be blood at the meatus, and a palpably full bladder. On a digital rectal examination, we may find a high riding prostate, which is suggestive of a puboprostatic ligament avulsion. Urethrography. Immediate urethrography, RGU, should be performed ideally as per the books to rule out urethral injury, although it may not be possible in acute settings. Some may also go for direct inspection by urethroscopy in lieu of urethrography in female with suspected urethral injuries. This image shows a retrograde uretrogram in a patient with pelvic fracture, shows complete destruction of the posterior urethra. So this is the radiological sign. It's called pie in the sky sign. It is just the elevation of the urinary bladder by a large pelvic hematoma, and it is suggestive of urethral injury. This is very important, the Goldman classification of urethral injury. So it was initially divided into 3 types, but later on it was modified by McCallum-Colapinto, which included the type 4 and type 5. So type 1 is just the stretching of the posterior urethra, which is due to disruption of the puboprostatic ligament, though the urethra is still intact. In type 2, the posterior urethra is injured above the urogenital diaphragm. In type 3, there is injury to the membranous urethra and it extends to the proximal bulbar urethra. In type 4, it includes the bladder base injury and it involves the bladder neck extending up to the proximal urethra. The 4 has been subdivided into 4A. We can just memorize it by A for absent bladder neck. So if the bladder neck is absent, only the base is involved, it is 4A. Then type 5 is, it is pure anterior urethral injury, isolated. The initial management is suprapubic cystotomy with the planned delayed reconstruction. This is a standard of care in men with severe posterior urethral injuries. So the delayed urethral injuries may be then performed on an elective basis within several months when the patient is fully ambulatory. Primary realignment, it is a brief attempt, may be done at a primary realignment of the urethral injury as recognized as an alternate option in patients whose condition is stable, and it can be done either acutely or within several days of injury. So some urologists, they do combined retrograde and antegrade flexible cystoscopy for realignment by some urologists, but it is but such attempts have been shown to increase the risk of infection, thus it is not recommended. And as per this meta-analysis by Light et al., they compared the primary alignment versus delayed surgery, and they found that the delayed surgery had better outcome with lower rate of fistula formation or stricture formation or erectile dysfunction. In case of incomplete urethral tears, it is best treated by stenting with a urethral catheter. And various studies have shown that a gentle attempt may be done at catheterization, and it does not convert an incomplete transaction into a complete transaction. In no case there should be traction should be placed after urethral catheterization, as it may cause incontinence. The delayed reconstruction, it is done at 2 to 3 months. The scar tissue, when the scar tissue is stable at the urethral disruption site. This allows the posterior urethroplasty to be undertaken safely. So the preoperative evaluation, cystogram and retrograde uretrogram, it should be obtained simultaneously. This is called a up and downogram. So the image shows a combined cystogram and a uretrogram 4 months after the pelvic fracture, which shows a complete posterior urethral disruption injury. And in the same patient, the postoperative appearance reveals a normal urethral caliber. Some urologists go for endoscopic treatment for like direct vision internal ureterotomy. It is done in case of incomplete urethral stenosis, like partial distraction injuries, for which early catheterization has maintained the initial urethral continuity. But this is not very much effective, and defects 1 centimeter or longer. The endoscopic procedure, like cutting through the pelvic scar to provide a channel between the 2 ends of the avulsed urethra, which is called the cut to the light procedure, They have been done, but all the analysis, meta-analysis, and the research has shown that it has been ineffective. So the gold standard is the surgical reconstruction with open posterior erythroplasty. The perineal anastomotic approach is the treatment of choice. It cures the patient without the need of multiple procedures. So the posterior urethral anastomosis, we have to go via perineal approach alone. And this has been shown to be successful in majority of the cases. The adjunctive maneuvers include corporal splitting, in which we can split the corporal bodies, inferior pubectomy, and corporal rerouting. They may be implemented if the direct anastomosis is difficult or there is tension in the anastomosis. This is the intraoperative view of normal membranous urethra after the fibrotic tissue has been excised during perineal bulbomembranous urethroplasty. Combined abdominoperineal approach may be done in case of severe fibrosis or in case of previously failed anastomotic urethroplasty or in case of a bladder neck injury and in pediatric cases. So the complications include erectile dysfunction. So impotence, the rate is approximately 50%, and the etiology is multifactorial. And it is variably attributed to the cavernous nerve injury, the arterial insufficiency, the venous leak, and the direct corporal injury. So these patients, they're most vulnerable to these stenosis after posterior urethroplasty as a result of the bulbar urethral ischemia, very important. And some experts, they suggest that at-risk patients should undergo preoperative arterial duplex Doppler study to identify the candidates who are suitable for initial penile revascularization. Then comes restenosis. The restenosis rate is 5 to 15%. And the endoscopic treatment like direct vision internal ureterotomy is often successful in this setting because the most fibrotic tissue has already been eliminated. Incontinence. The incontinence rate is very less. It is less than 4%. And very important, continence after the distraction injury is the rule rather than the exception. And it has been seen that despite destruction of the external sphincter, the patient is continent. Now coming to the anterior urethral injuries, the etiology includes, they are mostly, first of all, they are mostly isolated, and they mostly occur after straddle injury, and it involves the bulbar urethra, which is more susceptible to compressive injury because it is fixed, it has a fixed location just beneath the pubis. The clinical indicators include blood at meatus, perineal hematoma, there may be gross hematuria, or the patient may have urinary retention. And similar to the pelvic fracture, it needs prompt urinary drainage through either a suprapubic tube placement or a urethral catheterization with a fluoroscopic assistance. And the primary morbidity of straddle injury is a urethral stricture, which may be formed after a few months. The initial management, the gold standard is the suprapubic cystostomy. It is standard of care in major straddle injuries involving the bladder, involving the urethra. The primary surgical repair is recommended for low velocity urethral gunshot injuries. The delayed reconstruction, it should, before the delayed reconstruction, a retrograde ureterogram and a voiding cystourethrogram should be obtained preoperatively. And it is used to define the site and the length of the obliterated urethral clearly. Ultrasound imaging of the strictures is although more accurate than the retrograde ureterography, but it is not performed because it is highly operator dependent. So it is not widely used at present. The anastomotic urethroplasty, it is the procedure of choice in total obliterated bulbar urethra after straddle injury. Endoscopic incisions have been done in case of straddle injuries, and all the data research work has shown that it has no good result, and it is a hopeless procedure, and it is doomed to fail. And repeated endoscopic manipulation is neither clinically effective nor it is cost effective for the patient. So this is a very important flow chart which summarizes my slide. So in case the patient has suspected lower urinary tract injury based on the history and the physical examination, like suprapubic ecchymosis, low abdominal tenderness, pelvic fracture. There may be a hematuria or a total perineal ecchymosis, high reading prostate. We have to suspect a low urinary tract injury. So the patient may be hemodynamically stable or hemodynamically unstable. If the patient is hemodynamically stable, ideally we should go for a retrograde cystogram and a retrograde urethrogram. If there is an extraperitoneal bladder injury or a posterior urethral injury, we have to determine whether the injury was complex or not. Complex includes all the features as explained before, like the involvement of bone or concomitant penetrating injuries. So if all these are not present, only urinary drainage may be done. And later we can go for a delayed repair of the bladder or the urethra. But if it is involved, if the injury is complex, we have to go for exploration and repair there and then. If the intraperitoneal bladder injury is there, we have to go for exploration and repair, and along with that, urinary drainage. In case of anterior urethral injury, we have to determine whether it is a penetrating injury or not. If it is a penetrating injury, we have to go for immediate exploration and repair along with urinary drainage. And if it is a blunt injury, we may just go for a diversion or urinary drainage, and delayed repair may be done later on. If the patient is hemodynamically stable or some other reason for which abdominal exploration is being done, so the patient is already in expiratory laparotomy, so we have to check for anterior urethral injury. So we have to check whether the patient is stabilized or not. If stabilized, then we can go for exploration and repair in case of penetrating injury. If not, just drainage and delayed repair. And in case of intraperitoneal bladder injury found during laparotomy, we need to go for direct exploration and repair with urinary drainage. In case of extraperitoneal bladder injuries or posterior urethral injury, we have to see whether the patient is stabilized or not. If the patient is stable, we again have to check whether the injury was complex or not. In case of complex injury, we have to go for a direct exploration and repair, and along with that, urinary drainage. If not, we can just go for urinary drainage, and a delayed repair may be done later on. So after all these procedures, before the removal of the catheter, it is very important to go for a retrograde cystourethrogram prior to removal of the catheter.
How would you do
Thank
a
you.
urethrogram prior to removal of the catheter? How would you do a urethrogram where you said inside the last? Go back to your last slide. इसमें लिखा है कि you do a urethrogram prior to removal of the catheter. So basically, what you're trying to say is a pericatheter study.
Yes.
So you have to change that into urethrogram. You cannot do a urethrogram with a.
It is already
Pericatheter.
Pericatheter.
Study.
Yes.
Right. So just unshare your presentation. Yeah. So thank you, Dr. Sudeep, for the presentation. So do we have Dr. Pankaj with us? This is not coming. Sound is not coming here. Apna icon. Nimesh ji, do we have Dr. Pankaj with us?
Not sir, not joined.
Recording in progress.
इसको बंद
Sir?
कर दीजिए. Yes, yes.
Not joined yet, sir.
Okay, okay. Anyway. So इसको म्यूट कर दीजिए, इसको बंद कर दीजिए. माइक को बंद कर दीजिए.
No, sir.
Nimesh ji?
Yes, sir.
Has Dr. Pankaj Joshi joined?
No, sir.
No, no, sir.
Okay.
Perfect. So,
Nachiket, would you like to say
I
anything?
think that yesterday also we had a case of PFPG, so you have still left many things, unanswered about what is the present status of, realignment or endoscopic realignment. It would have been appreciated if you have gone to the literature and see what the status and how primary endoscopic realignment helps us in 2022. This again, time and again, I mean, I don't think there is a different touches on this. Namutla again, why are they shifting to what are the policies of MR? And I think that technology point also on the platform. So those relations will remain and at the same time, in the case of anti-urethral, the pathophysiology and anatomy. By anti-urethral pictures, they just remain confined to the perineum with butterfly hematoma forming. What is the anatomy? What is the physiology? When will the urine seep into the axilla? These are still things that you still repeatedly, you do not touch. I don't know. I think that you should touch over there. And again, you have to go into what is happening in 2022 because I think all of us know what this is. I mean, you told about everything. So this is relevant to.
Nachiket, we have added a few things on realignment because realignment is still a debatable topic. It's not totally obsolete. I know there was meta-analysis just a couple of years ago where they did comparative study between primary realignment and doing urethral. So what they found only 9% of these patients didn't require any kind of or surgical management. So 9% were without any kind of surgical intervention. So they saw that there's 30 to 40% require at least a kind of thing that need more work into is that whether primary realignment can help at least some of these patients. They said that primary realignment again early and delayed. So early is usually done within 42 hours. So in the acute setting, what I said, it could be diagnostic. The flexible cystoscope can be diagnostic, plus it could be therapeutic. So what I said, early is usually done within 42 hours. And there is diagnostic, which is usually done between 5 to 7 days. You have already put a suprappubic cystostomy, and then you go both antegrade and try to retrograde find out the area of hematoma, or try to pass a guide wire, and then if you can pass the guide wire into the bladder, then put a catheter over it. So that is a delayed primary realignment. And then what you discussed about the realignment after the kind of 2-3 months after putting surgery, that is cut to light. So that is almost obsolete. Nobody probably agrees with that. But realignment again could be a thing which needs to be worked.
You should also have in the guidelines which have been given by the USA and also the consensus statement, because now we are guidelines for many things, and actually Dr. Sanjay Kulkarni was the chairman of guidelines of USA for urethra. So should I also in the line what the consensus statement is?
Yeah, I think that's a good presentation. Whenever you do a kind of a presentation, try to put a slide on guidelines. And because we have our own guidelines, urologists in India, if they have already, we should try to encourage that, putting that, because they have worked so hard for making these guidelines. And secondly, you can also put guidelines of the AUA and EU also what they suggest about your colleague. So, two or three slides on guidelines.
That would also be important.
Anything
else? Anybody?
Okay. So thank you. Thank you, Sudeep. Thank you, all the residents. Thank you, all faculty members, and all those who have joined us today
on YouTube or Zoom.
Dr.
Ajay, just give a word of thanks and then we'll wrap up the session.
Thanks, Dr. Sudeep Singh, for knowledgeable presentation, and Singh sir for enlightening us valuable information about state.
So thank you, everybody. And